In the early morning hours of their shift, a fire truck responded code 3 with right-of-way on a major thoroughfare. A small car ran a light and was broadsided by the fire truck. One of the young occupants in the car was killed immediately. The other, after extrication, was taken to the local trauma center in critical condition, declared brain dead, then became an organ donor. After some time had passed, I joined staff from our local donor services organization where I volunteer, and we visited the crew. A number of interesting questions came up during our visit, questions which many other first responders may also want answered. And to find out, we sent a survey to local firefighters, EMTs, and paramedics. Close to 400 participated, and we found that almost 90% had received no formalized training on organ and tissue donation, and they thought continuing education programs should include the topic of donation. The following program is not to tell you how to do your jobs, and we aren't here to change your protocols. We aren't going to train you. This is a film of a fictional account of an accident victim who becomes a donor, played by me. We've included face-to-face testimonials with real people sharing real stories or facts. And you'll see what typically happens behind the scenes when you've done everything you possibly can to save the life of a severely brain-injured patient, and they go on to become a donor.
My daughter Danelle, 25, had dropped her son off at daycare and went to run errands. As she was on her cell phone, she ran a red light as a cement truck was making a left-hand turn. She was fortunate to receive immediate attention by an off-duty officer and the fire department. I do believe it was that immediate care that helped set the stage for her to become an organ donor.
Engine 21, truck 21, medic 21, vehicle accident, one victim, male, non-responsive, second victim, a female, East caller, located westbound on Taylor before Shell Street.
Yes, sir.
Many first responders may have experienced a moment like this. After rapid trauma assessment and evaluation, especially in cases of critical head trauma, it can be difficult to ascertain the survivability of victims. Sometimes patient outcomes are not those first responders hope for as they provide care in the field. Non-resuscitated patients cannot become organ donors. This may not be common knowledge among many first responders. Maintaining patient viability with your BLS and/or ALS protocols is essential for possible organ donation. Your life-saving efforts in the field, even if the patient suffers non-survivable injuries, could help save up to 8 other lives through organ donation. Here are some ideal in-the-field care protocols which support successful outcomes for potential donors. IV access, 18 gauge preferred, but any access is better than none. Fluid resuscitation per protocol to maintain adequate perfusion. A mean arterial pressure of greater than 60 is preferred. Adequate oxygenation with bag valve mask or intubation. Intubation is preferred to protect the airway from aspiration. And a legible and complete run sheet.
On November 10th, 2007, my son Jordan was in a fatal car accident. The gentleman that he ran into happened to be an EMT, was able to pull Jordan out of the car and administer CPR immediately. Rescue Fire Department was less than a mile away and responded immediately and were able to continue the CPR. At that time, Jordan's heart stopped. They paddled him in the field, was able to get a heartbeat, stabilize, start a line, and able to transport him. Jordan was going to be a third-generation firefighter. He was an incredible young man. He wanted to carry on the legacy that our family started more than 50 years ago. And unfortunately, his first call and last call was his final call, but not for 3 people that were able to live on because of him, because of the people that responded to the scene and did everything exactly the way they needed to do to be able to stabilize Jordan so that he would be a viable donor.
Organ donation primarily occurs following brain death, the irreversible cessation of all brain and brainstem function, or after a significant head trauma, which leaves the family with no hope for any meaningful recovery for their loved one. Brain death occurs when trauma to the brain causes a subsequent loss of all blood and oxygen flow to the brain. Common causes of brain death include trauma to the brain caused by such things as a motor vehicle accident, a gunshot wound to the head, or a severe blow to the head. An intracerebral bleed brought on by an aneurysm, head injury, or hypertension. A brain tumor. Anoxia, which is a lack of oxygen to the brain caused by such things as drowning, drug overdose, hanging, heart attack, respiratory disease, or poisoning such as carbon monoxide. Less than 1% of all hospital deaths in the United States annually are eligible to be organ donors. Organ donation requires the potential donor to have intact pulse and blood pressure along with effective perfusion and oxygenation. Aggressive resuscitation efforts are instrumental both in the field and during transport for any successful donation outcome. Once oxygenation and perfusion are stopped, organs begin to die and are no longer viable for transplant. A thorough patient care report or run sheet is vitally important to hospital personnel to determine the potential for a timely referral to the local organ procurement organization.
Good evening, Drama Base. This is Firecopter 1 inbound to your facility with an ETA of 3 minutes.
Copter 1, this is Trauma Base. Go ahead with your run.
On board, I have a 45-year-old male, GCS of 3 right now. It appears that he has a basal skull fracture. We are breathing for him right now. He is intubated with a...
We got a trauma coming in, 3-minute ETA.
What do you got, Mary?
We got a 45-year-old male out in the field who's being brought in by helicopter in 3 minutes. He's got a GCS of 3. He's intubated. They're assisting respirations. He's got a 16-gauge IV, and his blood pressure is only 75 palp, so he's pretty bad off.
All right, you said he's only got 1 line in?
Yeah, they've only got a 16-gauge.
All right, why don't you go ahead and set up for a central line, hang a bag of Levofed, keep his pressure above 60, a couple liters of normal saline while you're at it, too. Now, you say he's got major head trauma?
Yeah.
Okay, why don't you go ahead and notify donor services and while you're at it.
All right, sounds good.
Cool, thanks.
Under federal regulations, when a patient meets certain medical criteria, the hospital must make a referral to the local organ procurement organization, also referred to as an OPO, or sometimes donor services. So what is the medical criteria for donation referrals? All patients who have a severe neurological injury and are on a ventilator regardless of age or diagnosis. Criteria can change slightly across the United States.
Hey, Mary, did you put that call out donor services?
Hey, yeah, good call on your part. Actually, this patient meets screening criteria for organ donation, so...
Yeah, good. A couple weeks ago, we didn't put that early referral call out, and so when we finally got around to doing it, and they showed up, by that time the patient already crashed. If the families want to donate or the patient's registered and we lose that option, it can be quite traumatic to the family.
Yeah, I heard about that case a couple weeks ago, so awesome call on your part. Actually, looks like the patient's here.
All right.
Multiple times throughout my nursing career, I've been responsible for phoning in a referral to the donor hotline regarding a patient we're working with. When the patient's primary injury is to the brain, that referral is fairly obvious, but we need to think larger about neurological injury. For example, the nurse might be working with a patient who had a large heart attack, was under prolonged CPR, and is intubated and sedation's been held, and then the patient's just not responding. There's really questions about a hypoxic brain injury. That patient meets all the criteria for a clinical referral. Nurses at the bedside 24/7 are really crucial in evaluating patients for hypoxic injury and facilitating early referrals. And by early and timely referrals, we're really talking about within an hour of that patient meeting clinical criteria. When you call into the donor hotline, they ask questions about the diagnosis and the mechanism of injury. They also want to know really specific assessment findings. What are the pupils like? Are they equal? Are they reactive? Is there the presence of a cough and a gag reflex, either spontaneously or when you suction the patient? And is the patient breathing at all above the rate set on the ventilator? All of those findings give them a clearer picture about brain stem function and about where the patient is on that continuum of neurological injury. Now, early and timely referral does not mean the patient is brain dead or going to progress to brain death, but it does allow for evaluation and tracking, and it keeps that option for donation open. When we don't make timely referrals and there's a point where the patient's family has to make those kind of decisions, we may have lost the opportunity for donation, and that represents another point of grief for the family when they're already experiencing significant feelings of grief and loss.
Hey Mary, where are we at with things?
You know what, I just finished suctioning him, and
Any cough, gag, or anything like that when you suction?
you know what? No cough, no gag. He's actually got a GCS still of 3, really no response. I've got a bed up in trauma neuro ICU, so we're going to get him going upstairs. But I noticed on the run sheet that he had really good tissue perfusion and oxygenation out in the field. He's got really stable vital signs right now, so that's a really good call on the donor services thing. And I was wondering if you want me to, is the wife you want me to have her come in and see him before he goes upstairs?
No, actually, I'll go out and I'll meet her now and touch base with her and let her know that he's got a poor prognosis, as well as that neurosurgeon actually came and saw him also and determined that, unfortunately, he's not a neurosurgical candidate. Unfortunately, at this point, it kind of leaves us up to doing brain death testing.
What is brain death testing? Most states require 2 licensed physicians to perform independent, thorough neurological clinical exams. The doctors assess for the following: oculomotor reflex, no pupillary response to bright light; oculocephalic reflex, doll's eyes, no ocular movement to brisk side-to-side head turning; trigeminal reflex, corneal response, no eye blinking with gentle touch of swab to eye surface; ocular vestibular reflex, cold calorics, no deviation of the eyes to rapid irrigation of 30 to 60 milliliters of cold water in each ear; glossopharyngeal reflex, no cough or gag reflex after stimulation; areflexic, no head, shoulder, or upper extremity response to central pain stimulation; absent respiratory drive, no spontaneous respirations, to be confirmed by apnea test. The American Academy of Neurology recommends that confirmation exams be conducted in conjunction with brain death exams. Those confirmation exams may include an apnea test, electroencephalogram, EEG, or studies of blood flow to the brain, CBF. For states that require a second brain death note, the legal time of death is when the second physician writes the second brain death note.
0.08 mics per kilogram per minute, and it's Actually, keep it on.
Excuse me. Hi, my name is Ginny Janicelli. I'm from the Oregon Procurement Agency. I'm a family care coordinator.
A family care coordinator may meet with hospital staff for the first time to discuss a patient referral, anywhere between 30 minutes from the time the patient arrives at the hospital up to 5 days, depending upon the progression of the injury. If the patient had previously signed up on an organ and tissue donor registry, this is when the family care coordinator would share that fact with hospital staff.
Option for organ donation. Does that sound all right with everyone?
I asked everybody to come together so we can kind of have an understanding of what's going on from this point forward. I've conducted the first clinical brain death exam on Mr. Johnson and asked neurosurgery to come by and see him, and they actually did the second brain death exam. So at that point, he is now legally dead. So where are you at with things with Mrs. Johnson?
Well, we met with his wife, let her know that he had been declared legally brain dead. She was fairly upset, but appeared to have an understanding of everything we were telling her. I think she's ready for the next conversation.
I also met with Mrs. Johnson. She was requesting some spiritual support, so I facilitated an anointing of the sick for her husband and also prayed with her and her husband. And now she's wondering what happens next.
Organ procurement organizations, OPOs, usually do not approach the family until brain death has been established and the diagnosis has been explained to the family. OPOs also like to give the family a space of time after the confirmation of brain death is given and before the option to donate is broached with the family.
Well, if everybody's in agreement, I'd like to be introduced to Mrs. Johnson.
That should be fun. We'd be happy to let you use the chapel if you'd like to do that.
That would be perfect.
Okay, thanks.
In our organization, we've never had a family come to us and say that they wished that they had not said yes to donation. But we have had families who've come to us disappointed, upset, even angry that the possibility of donation was taken away from them. That could happen because care of the patient was discontinued prematurely. It could happen because the process moved too quickly. But whatever the reason, they were deprived of the benefits that come from knowing that you've been able to make a decision that made a positive impact on other people's lives. The loss of your loved one was not totally in vain, and that their memory is always honored forever by the fact that they saved someone else's life.
Hello, Mrs. Johnson. My name is Ginny Janicelli. I'm from the Oregon Procurement Agency. I'm so sorry about what has happened to your husband.
Conversations about donation with a patient's family can take place any time after brain death has been declared and following hospital policy.
I can't believe this is happening. I don't know how to... I just don't know what to do.
I understand. I'm here to help you with some decisions, but before we start talking about that, what have the doctors told you about your husband's condition?
They told me that he's brain dead, that he's gone. But he seems so alive. It looks like he's still breathing. So I don't understand how that can be.
I know it can be very confusing, and it's very hard for families to understand. Their loved one looks like they're just sleeping and their chest is going up and down because they're on a ventilator and the machine is actually breathing for them.
Brain death is the total irreversible loss of function of the brain, including the brain stem. To determine brain death, clinical brain death examinations are performed under carefully controlled circumstances. The patient's temperature, electrolytes, and respiratory status, known as acid-base balance, must be within normal limits. The patient must not be under the influence of sedatives or paralytics.
Our family will be here later today, and God, this is happening so fast. We have things to talk about, and I don't know how long they can be here. And then what?
Well, I think I can actually help you with that, because your husband has made his wishes known. I looked him up on the donor registry, and he signed up to be an organ and tissue donor. He can actually help 8 people through organ donation and over 50 people through tissue donation.
Yeah, he told me he'd signed up. He wanted me to do it too. Is this definite? I mean, is this...
Yes. This is a legally binding document. These are his wishes.
Signing up on a donation registry ensures that a person's expressed wish to be an organ and/or tissue donor after death will be carried out. A person's desire to donate is stored in a secure, confidential database. Family members are provided with proof of the donation registration at the hospital so that their loved one's life-saving wishes can be fulfilled. If a potential donor is not signed up on the registry, the family is approached for consent for donation. Typically, this is done by a family care coordinator with full support and cooperation from the attending physician, nurse, social worker, and/or hospital chaplain. This conversation is conducted with the utmost respect, dignity, and consideration for the family and their loved one.
So, how does this process work? What happens next?
Well, your husband will remain in the ICU where he'll receive the same respect and care that he's been receiving all along. You're welcome to come and stay with him as well as your family. The transplant coordinator will come and begin placing the organs.
How do you find recipients?
Well, they're chosen by their blood type, how sick they are, and how long they've been waiting on the transplant list.
When I think of fairness, I think about the organ allocation system. Organ allocation system renders organs to those who need it most, and it's based on those who may die soonest if they don't receive this organ. So those who are sick in an ICU are going to get that organ before someone who's walking around and doing well. Those who meet the same physical characteristics of that patient, such as I'm 6'5", my liver would not do well in someone who's 5'1". Also, it really depends on how long you've been on the waiting list. So someone who needs a kidney, who's been on a waiting list for 5 years, is going to receive preference over someone that's been on the waiting list for 2 months, which is fair. And also, geographically, if you are in New York and you donate organs and someone's in Hawaii that's a recipient, that's not going to work. There's going to be a lot of damage to the organ. So those individuals within that same geographic area are going to receive precedence.
I think it's the right thing to do. He was...
After the family has consented to donation or has been advised that their loved one is on a donation registry, the essential tasks of the organ procurement coordinator begin.
Help somebody else live.
As an organ procurement coordinator, I and my colleagues thoroughly evaluate and medically manage the potential organ donor. Our job is to collect all information necessary for transplant physicians to make good decisions regarding transplanting organs into their intended recipients. This begins with a review of the patient's hospital chart, starting with the EMS run sheet up to the time a patient becomes an organ donor. The EMS run sheet is very important because first responders are the front line of patient care, and with most donors, this is the first medical management provided. The EMS run sheet gives us the timeline of the patient's pre-hospital course and shows the patient's status when EMS arrived and any medical interventions provided pre-hospital. If CPR was performed, we want to know if it was bystander or EMS initiated and the duration. A short duration and performed by trained medical staff equals more viable organs for transplant. The run sheet will tell us if the patient was intubated, pre-hospital, or bag valve mask ventilated to the hospital. We can ascertain if the patient vomited and possibly aspirated, causing lung donation to be more difficult. All of this information alerts the transplant coordinator to any impending complications we may have with the donor and allows us to be proactive with any necessary interventions. Approximately 12 hours are spent on evaluation and medical management to optimize organ function. The next step in our job is to locate recipients for the organs deemed transplantable. The allocation process may take 12 to 24 hours, depending on the number of organs being allocated and their overall function. The organs are allocated using a national database, the United Network for Organ Sharing, which maintains the list of patients in need of life-saving organs. Ultimately, it is the decision of the receiving transplant center to decide if an organ from a donor is a good match for their recipient. By using a national database, the system is fair, and the limited number of donated organs are efficiently and effectively allocated, ensuring patients with the greatest need are transplanted first. Although up to 8 organs can be transplanted per donor, reality is that the national average is just under 4 organs per donor. All of us, from first responders, hospital personnel, to transplant coordinators, have the ability to increase this number with good patient care and donor management. Should the patient become a donor, despite all life-saving efforts, early fluid resuscitation, adequate oxygenation, and airway protection lead to fewer hospital stay complications and more organs transplanted per donor. What's good for the patient is good for the donor, and it really all starts in the field with the ABCs and you, the first responder.
Transplants are accessible and available to everyone. Celebrity status and wealth do not enter into the equation. Becoming a donor will not affect the quality of medical care. Organ recovery takes place only after all life-saving efforts have been exhausted. There is no cost to the donor's family or estate for donation. People of all ages and medical histories can be donors. All major religions support or permit donation, and most consider it a gift, an act of charity.
I'm the minister of a very large interfaith congregation where we invite leaders from all of the great religions and spiritual traditions to come and share their wisdom with us. I have access to these leaders, whether they're Buddhist monks or Hindu priests and nuns, Catholic priests, rabbis, imams, Native American holy men and women. And I've asked them what their tradition says about organ donation. And in virtually every case, they enthusiastically endorsed organ donation.
Being the mother of a son with a rare liver disease is really hard. The fact that eventually someday he's going to need a transplant and possibly be on the waiting list is even harder. Connor's an amazing kid. I think I can say for both of us that we're both really grateful for EMTs, paramedics, nurses, and doctors that have already saved his life and that most likely will save it again in the future. It's allowed him to live his dreams. This summer he'll be riding his bike across America to raise money for organ donation research, awareness in the registry. And we can't fix Connor now or today, make him healthy, but the things that we're able to do because of the paramedics, the EMTs, and all the people that have helped him will hopefully be able to make it better in the future.
I'm really grateful for all the EMTs, doctors, and nurses that have saved my life in the past and probably will in the future again. And without them, I probably wouldn't have been allowed to do all these great things.
Transplantation is no longer considered experimental. It is a desired treatment for thousands with end-stage organ disease. Medical breakthroughs have improved success rates for transplantation. It now generally runs in excess of 80% for transplants overall. In order to be viable, organs must be recovered from the donor via surgery and then transplanted within hours. The heart, 4 to 6 hours. Lungs, 6 to 10 hours. Liver, 12 to 24 hours. Kidneys, 24 to 48 hours. Pancreas, 12 to 24 hours, and the intestine, 12 hours.
As a perfusionist, one of our roles and tasks that we do is to assist the different teams to come to recover organs. Not all teams have a perfusionist with them, therefore it's time sometimes we take over and do it. Of all the teams that we have, each team sometimes can be composed of 4 members. So you can imagine in an OR when you have 18 different staffs in there, it can be a little bit chaotic, and that's when our role is important. We become the middleman between the hospitals and the transplant surgeons. We communicate with them. We ensure that everything that is needed, it is in place, as each organ is very viable once it's out. Once the organs are out, each organ gets packed per UNOS protocol, and each respective team that came for that organ will be taking that organ with them.
More than 100,000 people in the United States wait for a life-saving organ transplant. 1 out of 3 people on the transplant wait list die due to a critical lack of life-saving donations.
Hi, my name is Brian Hinesley, and I'm actually a Los Angeles County firefighter paramedic and have been for the last 20 years. 9 years ago, I received a life-saving liver transplant that completely changed my life. I was within hours of death. I'd lost over 100 pounds. I didn't recognize my family anymore. I had absolutely no strength or energy. I'd been off work for 3 years. After my transplant, I healed well enough from my transplant to return to work as a firefighter paramedic, to continue to do the job that I care so much about, to help save lives, enhance lives, and in the rare instance when we aren't able to save the life of the person we're working on and they become an organ donor, it's a very special thing to me and also my crew and family to know we did all we could for that person, but they went on to become a hero. They became an organ donor.